So we do not have a video for the last session. I will be your video. The debate about the physician aid in dying law was highly visible and highly charged. And the passage of the law led us to decide that this was something about which there was a need for responsible dialogue. Suicide is among the leading causes of death in the United States. Around 110 people commit suicide every day in this country. Moreover, the risk goes up with age, especially in men. Here in Orange County, women over the age of 85 are at twice the risk to commit suicide as the general population. And men over the age of 85 are at 4 times the risk to commit suicide as the general population. Estimates of suicide among Alzheimer's disease patients range from less than 1% to nearly 10%, depending on the nation in which the study is performed and the specific population that is examined. What is largely consistent, however, is the risk factors for suicide among Alzheimer's patients. In this slide, the bolded risk factors are ones that are highly replicated findings. Men who have a history of depression, insight into their cognitive impairment, and access to firearms have been shown consistently to be those at greatest risk for suicide among Alzheimer's disease patients. The debate on physician-assisted suicide in Alzheimer's disease has been going on for some time. Recall that Jack Kevorkian's first case of assisted suicide was a woman with Alzheimer's disease. The debate is complex. It is certainly true that Alzheimer's disease is fatal, the source of great pain and distress, and that patients could be said to be in need of such assistance. Alternatively, slippery slope arguments have been made that physician-assisted suicide could reduce the use of palliative care, lower the imperative for research to improve end of life, and even lead to accepted euthanasia. Furthermore, there is a debate in the Alzheimer's disease literature in which both sides argue that respect for autonomy could either demand or forebode planned suicide in Alzheimer's patients. This argument treats an Alzheimer's patient as 2 individuals, a person who makes a plan while cognitively intact, and a severely demented individual who may fully enjoy life in a situation far different from that which they expected. Of course, Alzheimer's disease fundamentally affects decision-making, creating complexities for any law or policy on this topic. This slide articulates decision-making in the medical setting across the course of Alzheimer's disease, revealing that ultimately, patients will depend on others completely for medical decision-making. These complexities may result in what's observed in the first year of the existence of the California physician aid in dying law. No single case of prescription using the law was given to a patient with Alzheimer's disease. With this as our backdrop, the plan for the remainder of our session is that we will have a talk on the law itself, and then we will enjoy a panel featuring a psychiatrist, a neurologist, and a palliative care physician. So it's my pleasure to now introduce our speaker for the law, who is widely known here in Orange County, Blix. By all means. Faye got her JD at Western State University College of Law and has been practicing law here in Orange County since 1984. She devotes the majority of her practice to addressing the legal problems of the elderly and those living with disabilities. She was among the first group of attorneys in the country to be certified as an elder law attorney by the National Elder Law Foundation. This happened in 1995 for her, and she's an accredited attorney by the Department of Veteran Affairs. Thank you, Faye.
In 2014, the optics for the Aid in Dying movement changed dramatically from the rather eccentric, bombastic old man Dr. Kevorkian to the beautiful Brittany Menard, who had been diagnosed with stage 4 brain cancer and forced to move to the state of Oregon in order to have her wishes honored. Brittany's dying wish to her parents was that they would forward the legislation in California to be sure that no one else had to do what she had to do. And so after 2 decades of failed attempts in the state of California, the California Medical Association switched its position from anti to neutral, and in an emergency final session, the law was passed by a fairly significant majority in both the Senate and the Assembly and sent to the governor to sign. Almost all of us were surprised that Jerry Brown signed the law. But he did so on October 5 of 2015 with the statement, "I do not know what I would do if I were dying in a prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by the bill, and I wouldn't deny the right to others." And so, with that signature, California became the 5th state to legalize aid in dying for the competent, terminally ill patient, for the allowing a physician to prescribe a lethal dose of a drug for the purpose of the individual having the right to be able to decide when and in what manner his or her death would occur. The law allows the prescription be given only under very specific circumstances, and it is designed to ensure that patients who request the option are doing so knowingly and voluntarily and have had the opportunity to consider their other end-of-life options. Physicians under the law have the ability to opt out, as do their institutions, and the opt-out is very broad. Now, although this passage of the law has been presented as a major victory for patients seeking greater empowerment and autonomy and control at the end of life, and it is certainly a significant piece of legislation for California, I want to make it clear that this law does not create a right to aid in dying. It is a permissive statute. In other words, it allows a willing physician and a willing, competent patient to be able to begin the process of this aid in dying. So who can access the law? Who has the right to request? And in this particular situation, it's important to note the person has to be over the age of 18, they have to be a California resident, they have to be terminally ill, defined as likely to die in 6 months or less. The request must be voluntary. The individual must have capacity to make medical decisions, must have the ability to self-administer, and also be able to do all the things necessary in the process, be able to follow through the steps. It's important to also note who cannot access the law, who cannot make the request. The law is seeking to protect a certain group of patients, and so anyone lacking mental capacity to make medical decisions cannot access this law. Anyone who cannot self-administer the drug cannot access this law. No one else can ask on the patient's behalf to access this law. Not an agent, not a conservator, not a caregiver. And no one who is trying to have an advance directive honor or a post can access this law. It can only be the individual. And it is a fairly daunting process. It is inherently designed to slow the patient and the physician down, to ensure that none of these decisions are made without caution. And it is to make sure that people have thought this through very carefully with various consultations. So when you look at this, the legal requirements that the law insists upon, as well as the practical challenges in our own very fragmented medical healthcare system, as well as individual trajectories of their own disease process, you have to be pretty strong to jump through all of the hoops. And as a result, we are hearing a fair amount of frustration from people who have tried to access the law. Now, when the patient makes the request, the intending physician is required to determine that there is a terminal disease. There's a 6-month prognosis. The request is voluntary. Person has capacity, has the ability to make an informed decision, and has met all the criteria. And they must refer to a consulting physician. The patient is required to make 2 oral requests 15 days apart, as well as 1 written request that is witnessed appropriately. The criteria for the capacity for medical decisions is the same as capacity for medical decisions for the advance directive. The ability to understand, to be able to weigh and analyze risks and benefit, and then also to communicate those wishes. And an informed decision is specifically defined under the Act, and the doctor needs to determine a whole list of things: the diagnosis, the prognosis, the possibility that the patient can choose to take the drug, but doesn't. They can choose to go through the process and then still decide not to use it. And probably one of the most important components of the law is that the doctor is required to make sure that all the alternatives of end-of-life planning are addressed. The attending physician must also counsel the patient, inform them of what their rights are. They can have someone else with them if they choose, but they are required never to take it in a public place. I guess the legislature was afraid there would be some kind of drama, and so it's very carefully outlined. It can't occur in a park or a street or whatever. The attending physician is also allowed to let the patient know, do you want to notify your next of kin? But the patient can opt out of that notification. They are suggested to participate in a hospice, and they are also required to keep the drug once it has been prescribed, to keep it in a safe and secure place until it is used. Here again, the law is trying to protect this group of people. The patient can withdraw or rescind the request at any time. And at this point, capacity doesn't matter. You can lack capacity and ask to have this rescinded. The doctor also has to verify in writing before the prescription is issued that the patient still wants the drug. So there are checkpoints all along the way, checklists, mandated forms. And if there is any situation where there could potentially be a mental disorder that impacted judgment, the attending physician can refer to a mental health specialist for an other analysis. They must also refer to a consulting physician. So there needs to be a second opinion. And the consulting physician is essentially doing just that. They're making sure the prognosis, the diagnosis, the capacity, the voluntariness, and they also are allowed to refer to a mental health specialist and required to complete documentation. The mental health specialist is a psychiatrist or a licensed psychologist, can't be related to anyone or likely to inherit from an early death, but under the most circumstances, they again are looking for mental capacity, determining judgment is not impaired in order to make this decision and to document those findings. The prescription itself cannot be written until all of those hoops have been jumped through. So the attending physician has to confirm that all the legal requirements have been met. The law is not specific with regard to which drug is used, and the physician cannot just give the individual a prescription to take to a pharmacy. They either need to dispense the drug themselves or the patient needs to go to the pharmacy. Now, the main requirement once the prescription has been given is to be sure that the individual knows and the doctor warns one more time that you can change your mind at any time, but the individual must be able to self-administer. Other people can help prepare, but the actual taking, ingesting, swallowing has to occur with the person being able to do it themselves, not in a public place. Others can attend if the patient wishes, but the administration has to be alone, done by the individual alone. Finally, the physician has to report within 30 days to the Department of Public Health. The death certificate has caused some question. The statute says only that you cannot use suicide on the cause of death. What most physicians are doing now, I am told, is listing the underlying cause of death as the main item in the death certificate. Some people are including end-of-life option act as a secondary cause, but in that situation, it's important for you to know that the law says that no insurance or annuity or beneficiary designation will be impacted if someone chooses to make this choice. No physician or institution is required to participate. It's a very broad opt-out. And as you are probably aware, about 13% of our medical institutions are church-related in the state, and most of them have agreed to opt out, as well as the VA administration. They're not allowed to participate because they are federally, and this is a state situation. The physician is required to public report, and the Department of California Health, Public Health, is to prepare a report every year. So for instance, we just got the July report for the first 6 months, from June 9 to December 31. Now, what I think we really care about here today is, how does this all apply to our people? How does it apply to those with Alzheimer's disease? And the main fact is that it doesn't. Because you must have mental capacity at the time you request the prescription, and you must also have a terminal illness with the likelihood of dying within 6 months. And for most of us, the capacity to make this kind of choice is lost long before the terminal phase is reached. In my practice, when people come to do planning for incapacity, many of them are very frustrated to learn that this act will not apply to them. And I've been surprised sometimes with the vehemence with which people have expressed the anger, and also with how strongly they feel. There is so much shame attached to an Alzheimer's diagnosis. I compare my clients coming in with Alzheimer's disease and those coming in with cancer. And it's a very, very different dynamic. And it breaks my heart. Because the agony that is associated with the loss of autonomy and independence, the stigma related to loss of cognition, and obviously we expect anyone to grieve their diagnosis, the shattered dreams, the loss of relationships, the financial stress. But what concerns me is when people discover that the act that they thought perhaps could save them is now not applicable to them, that we need to be particularly mindful and sensitive to the needs of our patients as they gain the diagnosis, so that they don't take matters into their own hands, realizing that it's going to be impossible for them to choose an end game if they're headed toward dementia. And so there's that horrible decision of trying to make the decision before I lose capacity, but not too soon, so I still have some life to live. And so a lot of us may not approve of this law. Some of us may feel very delighted by the law. But the fact of the matter is, the law does not apply to an Alzheimer's population. And so when there is nothing we can do about that, then I need to look at what can we do. And I'd like to shift the dynamic to see this law as an opportunity, a gateway to be able to start talking about dying. It gives you as providers the ability to be able to hear the question when they learn that the act does not apply to them, to be able to listen empathetically, to start the tailor advanced health care, to provide the open discussion, trust building, the reassurance of commitment to quality care to the end. And I guess what I'm really trying to say is, rather than us focusing on aid in dying for our people, we need to start focusing on aid in living. I've done a lot of thinking about why Alzheimer's disease and dementia is the most feared disease. And I think that the reason is that it's the way we as society treat the people who have this disease. We treat them as non-persons. And because of that, who wouldn't fear a disease like this? I feel strongly that we need to change the paradigm. We need to change our language. And this may seem silly, but are there points along the trajectory of the disease where we can change something negative into a positive. There's a retirement community, for instance, in Northern California, when a driver's license is taken away, that they have a car mitzvah. Okay. What about, when we send our kids to college and there's this wonderful kind of leave-taking, getting the room all ready? What if we were to turn the dynamic so that when we placed someone, it could be the same way? Our vocabulary, we talk about empty shells, already gone, loss of self, the long goodbye, living death, all of these kinds of things. What does that say about the disease? These people are human beings. And as you look at the wonderful photography, as I look at the memories of the making, have you noticed that almost all the paintings are peaceful? They're done in pastels. Shows that there's something going on behind the wall. And if our community could become dementia-friendly, so that every aspect, whether it's transportation, whether it is service providers, whether it's retail, if any of those people, if we could all be dementia-friendly, joining hands. So for instance, most of my people stopped playing golf because their buddies don't want to deal with them anymore. What if someone in the golf clubs decided to make that a dementia-friendly place? What if every male person in the county was aware? All of those kinds of things as we think it through. And is there a way in which, let's shift the dynamic. I love Dr. Flint's idea. We need to have a palliative care model for dementia that begins almost immediately after diagnosis. Can you imagine if hospice-type support was given to our people in the beginning while they still understood what a difference it would make, especially a palliative care community with a behavioral advice component? How many hospitalizations, how many family dynamic fights could we save if we joined together and made a difference? And so, in closing, I just want to give us all a challenge. Is it possible for us to make Orange County a pilot project? Is there a way in which we can engage our entire community to think through making dementia-friendly communities so that our people will never have to be concerned about not being able to choose aid in dying? Because, as Cicely Sanders suggests, last days need not be lost days. Thank you.
Thank you, Faye. That was excellent. I'm going to invite Drs. Flint and Dr. Ott back up to the stage to be a part of the panel. I want to introduce the third member of our panel, who is Dr. Ruth Benca, Professor and Chair of Psychiatry and Human Behavior at UCI. Dr. Benca did almost the entirety of her training at the University of Chicago, from medical school on to residency and fellowship in clinical polysomnography, and then was the director of the Sleep Center at Wisconsin for several years before thankfully being recruited to UCI in the last 18 months. So I want to give each of the panel members an opportunity to say a few words about the topic before we open the floor for questions, again by live microphone or by writing on one of the cards that you have available to you. So Dr. Benca, would you like to begin?
Sure.
There's a microphone right there.
Microphones help. Okay. Well, I think this was just a marvelous presentation, and I just wanted to add a couple of comments. As a psychiatrist, I guess maybe to start with the law itself. UCI is a site where we provide this service to patients. And one of the things, though, that we require is that every patient who requests this service must have a mental health evaluation, because we want to make sure that we verify capacity, but also make sure that the decision is not based on a mental health issue such as depression, which could be contributing to making that decision. I also want to add that I think it's, and again, I think Faye pointed this out, is that mental health services are really, I think, are one of the most important components of palliative care. And I think that's often neglected, and that part of quality of life has to do with kind of our mental state. And I think, you know, probably, unfortunately, I wasn't able to be here for Dr. Salzer's talk, but I'm sure he talked a lot about that. And then the final thing I want to say is to follow up on what Dr. Flint was saying, which is that, you know, in some ways, this law, like the Medicare rules for reimbursement of hospice care, you know, really have ignored this population completely, and the law, by definition, can't even be considered for patients. And so again, you know, I know people often have very strong views about that this is the right thing or not the right thing to do, but I think, you know, ignoring a large group of individuals who certainly some of them may think about these options is not appropriate. So I guess those are my comments.
That's great. That's great. Dr. Flint.
Great. Hi. Hi again. So my clinical practice is actually entirely based at the VA. So we're under federal law. Thus, no VA provider can actually participate in the End-of-Life Options Act. But I think Faye's last slide basically says everything that I wanted to say. Just because I'm not allowed to prescribe to my patients doesn't mean that people don't ask about it all the time. So I do think that the issue has elevated the discussion of dying in a way that's given me lots of opportunities to explore with patients and families. You know, tell me more. When people say, I heard about this new law, can you help me access it? I don't generally respond with, well, sorry, we're at the VA, you can't do that. I respond with, tell me more, and it usually leads to a pretty rich discussion of what troubles the patient and family are having and facing and what they're worried about, and kind of all those things that I listed in my little speech bubbles earlier. So I've found it to be a good opportunity for conversation.
Dr. Rupp.
I've been in practice leading a very large memory clinic since 1990. I think we now have over 6,000 people in our database that we've seen. And to date, we've had no patient commit suicide, which is much different than the figures that Josh mentioned. You know, why is that? I don't know. It may be we get a skewed group of people come to memory clinics. I would like to think it's because we are more dementia friendly. We have psychologists and counselors and social workers and a whole group of people, and we offer clinical trials which offer hope to people. And maybe that's why we don't see it as a problem. Alzheimer's disease is a disorder where the person changes. There's a lot of depression, certainly, particularly in the early stage of the disease, but eventually that gives way to apathy and confusion and loss of awareness. And that's the natural course of the illness. But you know, there are some things changing in the current environment worth commenting on. We're now at an age where we're recognizing Alzheimer's disease in people who have no symptoms, a preclinical stage. And we have a registry for people to participate in who are interested in that type of research and learning about brain health. And one of the things we did a couple of years ago was we did a survey of the people in the registry, and we asked them, you know, would you like to know your ApoE status or your amyloid PET status, if we could provide that for you? And 80% of the people in the registry said they would like to know that information. And then we asked them the reasons why, or what they do with that information. And by far and away, the most common response was, I think it was 85% of people said, so that I could participate in a clinical trial so that I don't get the disease. A very positive response. Others, the second most common response was, so I could adjust my life. I may want to retire earlier than I had planned. Again, positive. But as Josh knows, there were 12% of people who answered yes to the question, I would use this information to plan my death at the point where I started to lose my memory. So it is something that plagues people who are out there. They've been through what it's like to have a family member with a disease. They don't want it. And suicide is something seriously to contemplate in terms of what we call preemptive suicide. I know that's different than what we've been talking about, but it's another issue we may have to deal with more as time goes on.
Great, thank you. So the panel is open to questions, and the hands are going up. I was worried there'd be no questions. I'm kidding.
First question to you, doctor. You mentioned no patients. How many family members have committed suicide?
Can you repeat it?
You said, I mentioned no patients in our clinic have committed suicide, but how many family members or caregivers? There have been two. One was a husband who hung himself, and the other was a son who shot himself in the basement with his mother upstairs.
Hi, I have a question. After the medication is prescribed, is there a time frame that the person has to take it within? And then also, what happens to the medication if the person dies before the medication is taken?
I want to make one comment, but then I'm going to turn over to Faye for the sort of more technical components of the answer. So one of the issues that came up in some discussions that we had when, as a faculty group, we were deciding whether we were going to vote as an institution to offer this or not, is someone made the argument, well, in many cases when the medication is given, it's never taken. And that was supposed to be an argument of not voting for the law, or voting to be a site. And my argument was, as a sleep doctor, I prescribe a lot of sleeping medications to people who have insomnia, and the bottle of pills stays in their medicine chest forever, because just knowing that they have something in case they need it gives them a sense of control. So I said, well, actually, that maybe is the best scenario of the law, is that if a patient never feels they need to get to the point of using the medication, then we've done something right in terms of giving them ultimate control, but them being taken care of well enough with palliative care that they don't have to use it. But I'm going to let you answer the technical part.
And I'm not sure I can because I'm just an attorney, but I think the main thing is that the physician is required to notify the California Department of Health within 30 days of the prescription, of prescribing, and the individual must themselves sign a final attestation form 48 hours prior to ingesting, that says that it's voluntary and they know what they're doing and all the rest of it. My sense is, and I don't know how this works on a practical level, but if the patient does not take the drug within 30 days, that probably there is something that occurs. In other words, the prescription goes away. I know there is a requirement that they are required to turn in any unused drug within 30 days. But it is one of those areas that I think is a little loosey-goosey.
Yeah, I think from what I understand, you do have to appropriately dispose of the medication. And this is sort of a thing that I think people don't necessarily think about with these medications, but at the current state, the most commonly prescribed medication for the End-of-Life Options Act, I believe, is seconal. It's a very high dose. It's approximately 10 times the typical dose that people used to take in the days when people took barbiturates. We don't prescribe those very much anymore. And it's literally a handful of pills. It's because it is so much medicine, it can cause nausea and vomiting very shortly after taking it. So you have to take an anti-nausea pill about an hour before you take the medication. And the sort of average length of living after you take it ranges from hours to actually days. And so that's part of the recommendation for having hospice involved, because there could certainly be symptoms that come up after taking the medication. If people decide not to take it, the recommendation is to dispose of it by turning it back into a pharmacy that takes medications back, or not flushing it and actually mixing it up with like coffee grounds or something, substance like that, and putting it in the trash. And there's actually sort of guidelines for how to dispose of it.
So just so I understand, so what you're saying is that you can't, if you decide not to take it, but you want to have, that option out there, you really can't beyond the 30 days. Am I understanding that correctly?
Yeah. It can be re-prescribed. And I think some of this data came from other states that didn't necessarily have that 30-day restriction. So it's a little bit different in California, but I think the point is that what that data tell us is that this need for people to feel like they're in control and can make decisions until the end.
Because I think the data from the first 6 months, 193 people asked for the prescription, 111 took it, and I think 22 died before from the underlying disease process, and 59 we don't know.
Sorry, that was loud. So a lot of the arguments I hear against the aid in dying is that particularly vulnerable populations, maybe those with disabilities that feel like a burden, might feel more likely to take advantage of this. But in the presentation, it seemed like there were a lot of safeguards. Do you guys feel like there are enough safeguards to kind of dispel that argument?
I guess I always worry. It would seem from the data of the first 6 months that it definitely was not used by a vulnerable population. It was white, female, highly educated individuals who were on hospice. I guess the thing that worries me the most is, particularly with our healthcare structured the way it is, Alzheimer's disease is so poorly covered by Medicare and by other insurances that I think the financial burden and the desperation of the families in trying to provide care for their loved ones is enough to, I think, sometimes promote a feeling of a duty to die. The worrisomeness of being a burden to your family. And I guess that's why I was trying to get across the fact that I think we need to somehow change the idea. I mean, why is cognitive ability held so strongly in our society as opposed to affect? You know, it's like if we are not cognitively intact, or we need assistance with basic activities of daily living, that somehow makes us less human and less valuable. There's something wrong with that picture. And that's why I am concerned. There are definitely protections in the law. It would appear that the Oregon, the Washington experience, there's not a lot of bad press from that. It's more, there are some stories out of Europe, And I just read this morning that Quebec, this is kind of an interesting article, but Quebec, 91% of the caregivers wanted to make sure that Alzheimer's disease patients were allowed to participate in the aid in dying. It was just a striking statistic. So I think the slippery slope has potential.
Yeah, I mean, just to follow up on that, I think there's been more and more, even in the popular press, about the cost of end-of-life care in Alzheimer's disease, and the fact that, as the population is aging, and we're all hearing about how nobody's saved up enough money for retirement and end-of-life care, this disease can not only wipe out the savings of the patient, but also their children and other relatives having to pay for this, and that there are concerns that people will increasingly choose or feel pressured to end their lives simply because who's going to pay for it? And again, this gets into a kind of larger societal issues. If you want to.
If I could just add this anecdote that I was sharing with a couple of people of some of the unintended consequences of this law, I think it's related to your question. I had a consult in the past 6 months of an older veteran who had multiple medical problems, one of which was end-stage kidney disease, and he was facing dialysis. He also had some cognitive impairment, and but mild. And he was in a nursing home after a hospitalization, and had a bottle of oxycodone in his bag that he had from home, and saw some clips on the news about the End-of-Life Options Act and said, I don't want to go on dialysis. This seems like a way out. And so he took the bottle of oxycodone, all of it, and essentially became unresponsive, was rushed to the emergency room, got medication to reverse the oxycodone, and he was okay. But he was pretty pissed off when he woke up. And it was an opening, and we kind of got to the bottom of it with the assistance of our psychiatry colleagues and our kidney colleagues. And the bottom line was that he really didn't want to go on dialysis. It was not worth it to him to do dialysis to buy him more life. And so we had him transition into our hospice unit, and his mood improved tremendously, and he died about 2 weeks later, naturally from the kidney disease. But he heard End-of-Life Options Act and kind of took matters into his own hands, which I thought was pretty fascinating.
I just have another anecdote to add to follow up to what Faye said about, why do we regard loss of cognition as such a horrible thing that we should want to commit suicide or end our lives? One of my patients who has mild cognitive impairment is a very bright guy, and he goes to Manhattan every month and leads a discussion group, sometimes readings and so forth, and they pick challenging topics. And at one point he had chosen the topic of preemptive suicide, I'm still Alice type syndrome. And we had discussions about this, and he said in his group, where they all discussed this, very intelligent people, they were of the general opinion that if one has Alzheimer's disease, you lose your cognitive self. It's a cognitive death that occurs, and that is something that someone should be allowed to prohibit or put an end to, and because you're no longer your real self, and that's the rationale, I think. And I told him I didn't buy that. I said, you're really still yourself, but with Alzheimer's disease, you're returning more towards your childlike self, which you may not recall, but really it's a sort of a reversal of development. And so we had a number of discussions along this line, but now he's got dementia. He's progressed, and he hasn't arranged his death. He's still alive. He actually joined a clinical trial. And he doesn't bring up these topics anymore. He doesn't lead the discussion group either. But he's no longer so negative. And I think he came to grips with this whole idea of losing one's cognition, and he's okay with it now. But I think that's where that comes from.
I think we have time for one more.
Personal anecdote, my dad is a Marine, and when I was younger, he always talked like, well, hey, you know, when I get old and I can't care for myself, just, I'm done, just, you know, like that. But as he's gotten older, he's changed his mind a little bit, and he's willing to have a little of assistance. And I think people do change with time as they walk in that older person's shoes. But my question to you is this. How would we, if we wanted to have the people under this dementia umbrella access this solution, if you will, how would you foresee that happen? Would we capture their will upon early diagnosis when they were still lucid and then hold their feet to the fire 10 years later? How would you foresee that playing out?
I don't know, so I'm going to pass it on to my colleagues, but I just wanted to say thank you for raising the point that people's preferences change over time. It's anecdotally true for you, and it's absolutely borne out by research. And there's actually a psychological term, it's called, I think, forecast. I'm blanking on the term for it, but people's preferences change. They tend to adapt, and quality of life tends to stay pretty stable. Because we hear that all the time. If you have to change my diaper, you know, put me out to pasture. And that's, things change. But I'll let someone else answer the question about.
Yeah, I think the reason that we haven't dealt with it is that nobody really knows. And it becomes very, I mean, that's the thing about this disease. And, you know, again, as a psychiatrist, where we're mostly deal with issues of mood and cognition, the fact is that, you know, for all other diseases, if you have cancer or heart disease or lung disease or kidney failure, usually your mind is pretty intact and you can think about what you want to do. But we're dealing with diseases, and in this case, this disease, where that's the thing that gets taken away. So it becomes incredibly difficult to make a law about this, I think. And again, I was going to also share the anecdote of my own father, who had terminal cancer, and for years when growing up always thought, you know, I'm going to just end it all if I have something going on, and at the end, you know, really changed completely. So it's you can't really predict these things.
Yeah, it's a very difficult thicket, I think, ethical thicket, because when I have full cognition and I make an advance directive regarding these kinds of issues, and my then self now changes into my now self, am I imprisoned by the advance directive because my preferences now are very different sometimes? And I think all of us who have experienced this disease in our families, although there are many difficult times, there are tremendous moments of grace. And I think also that it is a situation where almost all of us, when we look at disability through our eyes, we see something very different from what we experience as disability for ourselves once we get there. There is a difference, I think, in that change. And so we can't predict it for anyone. So the only way I know of changing that is to try to make the environment for all of our people tolerable and loving, so that compassion is far more important than cognition.
So maybe I'll offer one final anecdote, which is that several years ago, I was serving as an associate editor for a journal that focused on Alzheimer's disease, and I was asked to serve in an editorial capacity for a manuscript that discussed planned suicide. In accepting the invitation to serve in this capacity in my communications with the senior editor, I made a comment about this being a suicide paper, and the immediate reaction was to say, oh, wait, I need to contact the editor-in-chief. We should reject this paper without review because of the topic. And I felt like that was not only a hasty decision, but it was absolutely the wrong decision. And the answer to your question, I think, is that we don't know yet, but we know that if we're ever going to get to a better position than we're in, we're going to need to have conversations. And those conversations are going to need to have many stakeholders, many different perspectives, be thoughtful, be respectful, and we were really striving to begin that here today. So I want to thank our audience for engaging in this. I certainly want to thank our panel members for engaging in this. We are at the day's end, and there are some other people I really must thank. First of all, I hope you'll join me in thanking the 4 remarkable caregivers who participated in our videos: Virginia Nave, Ben Allen, Barbara Ryland, and Roger Lisbeth. Certainly, I have to not only thank but commend the incredible staffs at UCI Mind and AOC, the people who did all the real work in putting today on. I hope that you've enjoyed it and you'll have an opportunity to thank them as well, especially Chelsea Cox and Carrie Walker, who really led this Herculean effort to put on, I hope, a really unique and exemplary conference. We hope that you will complete your evaluations so that we can do a better job still next year, and that you'll join us again. Thank you for joining us today.